Welcome back, everybody. We are now going to try and work our way through hundreds of questions. So no pressure to our wonderful panel here of speakers. We're going to try and get through as many as we can. Unfortunately, we don't have Dr. Frank Mano with us, but we can now invite Dr. Alan Hakim, as well as the speakers that have spoken today. Okay, so question for Professor Malfait. Which specialist, in your opinion, should be handling most of our EDS problems, dislocations, etc., when they're not vascular or other more of a crisis event, so more data stuff?
Well, good day, everybody. Hello, everybody all over the world. So I think it depends on what type of problems we are talking about, but if this would be musculoskeletal problems, yes, I think a physiotherapist is very important to be handling your problems. Orthopedic surgeon can be important, but it really depends on the underlying problem. Yeah, there are a lot of symptoms and signs that can be associated with EDS, and so they all should be looked after by the specific specialist that deals with these type of problems. If you have gastrointestinal problems, you have to go and see a gastrointestinal specialist, a cardiologist, etc. So it really depends on the underlying problem, and it could be any type of specialist.
Thank you so much. Question for Dr. Burrows. As we're all wearing masks these days much more, how can we protect fragile skin from tearing, particularly on the ears and face?
Thank you. Yes, certainly a new problem for us to consider, and it is something that we are seeing even in individuals who don't have EDS problems with long face mask wearing, particularly those in healthcare sector. A couple of things can be done. I mean, it's important to keep the skin moist in terms of helping with keeping it supple. So sometimes people will find that putting a moisturizer on will help with stopping the mask rubbing. If it really is an issue, then sometimes using very fine silicone tape over areas where you might find it particularly troublesome, such as over the nose. A lot of people find that they can find that the masks rub over the nose, and you can get this silicone tape. You can buy it over the counter in most countries, and apply that over the skin, and that will help protect.
Thank you very much. Okay, a question for Lauren. I know you touched on this a little bit on your talk, but people are asking, how do I get family to better understand, even if they aren't willing to listen or read material about the condition? I'm so tired of being doubted.
It's a really common question, sadly, for people with EDS, because it's not always visible to people from the outside what it is that patients are dealing with in terms of, fatigue and pain and all of those kinds of issues. I wish I had a more magic solution, but the things that people have told me have worked well for them are, number one, to really talk about their personal story and what do they do day to day? What is different from sort of the typical person's experience of their daily life? What adjustments are you making just to be able to function at the level that many of us take for granted? Sometimes those kinds of personal stories can help family see the parts of the struggle that they aren't seeing. Beyond that, there actually are great support groups if family are willing to talk with other caregivers and other folks who have a family member with some sort of chronic condition. If you have somebody who's not willing to read or do any of their own work, it is certainly more of a challenge. There was one other thought I had and I just lost it. I was going to say the other thing that sometimes helps is to take somebody with you through your routine, have them actually kind of walk with you, watch what you're doing, get a sense of what it is that limits you in a way that they might not have really understood without actually seeing, step by step by step, what are you doing to accommodate? So those kinds of things can sometimes be more meaningful if family members aren't willing to like read a paper or kind of take in information in an intellectual way.
Thank you, that's really helpful. A question for Professor Aziz. Do you recommend any diet or medicine to prevent chronic bowel obstructions due to abdominal adhesions in vascular EDS?
Sorry, Lara, is that for me?
Yes, please.
Yeah, okay. So no, I think the only thing I would say is that if there is a bowel adhesion which is actually causing obstruction, such as stenting of the bowel, which has caused narrowing, then one would recommend a low residue diet, which is low in fiber content, soft foods, so that the chances of developing a acute or a subacute obstruction are less, especially if the obstruction is higher up in the small intestine, because at that point the food may still not have broken down into very, very fine particles. But if there isn't any obvious obstruction there, in the sense of the bowel there's no demonstration on radiology that the bowel is in any way narrowed, then there isn't a specific need to alter the diet.
Thank you. And a question for Dr. Shalhub. Is an esophageal tear or perforation a sign of VEDS, and is this an indication for testing?
I'm not a gastroenterologist, but I can tell you just from reviewing the cases, there's one paper, and I think the link is already on the website, but if not, we'll find it, that summarizes the GI complications. So intestinal perforations are most commonly something that occurs in the sigmoid colon. There have been some reports of esophageal perforation, but they are very, very rare compared to the other complications. I guess I should say that how we want to investigate. We have a gastroenterologist on, right? Dr. Hakim is here.
Yes. Professor Aziz.
Yeah, no, I would totally agree with that. Esophageal perforations have been reported in very few case reports, but this is the more uncommon perforation that occurs, and bowel perforation is much more common. Tears in the lining can sometimes occur in a condition called eosinophilic esophagitis during endoscopy, which I mentioned in my presentation as well. But that doesn't necessarily mean that you have vascular EDS. So yeah, totally agree that esophageal tears and perforation are uncommon.
Thank you. And a question for Dr. Hakim. Is there a known correlation yet between EDS and POTS?
So great question, and I'll certainly cover this a little bit tomorrow, and we'll also have a talk from Professor Peter Rowe on Sunday about this. There's lots of literature now that describes the presence of POTS in a large proportion of patients that we see in our specialist clinics. So one of the things that we have to bear in mind is what's called selection bias. If we see the more complex patients in clinic, it is highly likely that they'll have a higher frequency or prevalence of many of these more complex conditions that we'll be talking about over the next couple of days. What we have to do is we have to look into the wider general population and try and answer several questions. The first question is, how common is POTS in the general population? Forget the diagnosis of another condition, but how common is POTS? The second question then is, how common is hypermobile EDS or HSD, which is a challenging question in itself. And then the third question is, how common is POTS in hypermobile EDS and HSD? as a whole population, not just those people we see in clinic. Only when we know that do we know whether there is a much greater likelihood of someone with POTS actually having EDS versus someone with POTS in the general population. It's a real challenge. What we do know is that in clinic we see lots and lots of people with autonomic disturbances. And my guidance to all of my clinical colleagues on echo, everywhere I work, and my guidance to my patients is, right now, the most important thing is that people recognize the signs and the symptoms of POTS and know that it can be treated, whilst we try and work out whether there's a strong association and why that might be.
Thank you very much. Question for Professor Malfait. What did you mean by a urine analysis for a molecular diagnosis, and can that be used to diagnose any EDS type?
Yes, yeah, great question. No, first of all, I'll answer the second part of the question. It cannot be used to diagnose all types of Ehlers-Danlos syndrome. It's very specific for some of the super rare types of EDS, specifically for the one that is associated with mutations in the gene that codes for lysyl hydroxylase 1, and that's the kyphoscoliotic type of Ehlers-Danlos syndrome. And we can look in urine for specific abnormalities in collagen, which are called collagen cross-linking abnormalities. And it's a very specific test for this type of Ehlers-Danlos syndrome. There is one other type, which is the spondylodysplastic type of EDS, caused by mutations in the gene that codes for ZIP13, but that's an exceptionally rare type of EDS, where the urine analysis is also abnormal. So no, it's absolutely not a test that can identify any type of EDS. It's especially used when we would find variants of unknown significance, for instance, in the gene coding for lysyl hydroxylase 1, and then we can look in the urine whether it actually causes abnormalities in the collagen cross-link. So it's a very specific type for a very specific analysis for a very specific type of EDS.
Thank you. A question for Dr. Burrows. Is it common for EDS patients to have numbing of the skin and may not be able to feel products like biofreeze or cyrogels when applied over joints?
That's not something I've come across. We know, of course, about the local anaesthetic story, so I won't repeat that. I mean, I would start to worry, is there actually some other nerve problem going on? Have they got an injury that's given them loss of sensation in that site? But it's not a recognized clinical pattern that we see that they have reduced sensation.
Thank you very much. And a question for Lauren. Are there factors that affect whether a rare disease manifests itself in childhood or adulthood, and can stress or hormones trigger it?
Sure. So I think the answer is yes. There are certainly factors that affect when a disease manifests and what those manifestations look like in different people. We know very little about what most of those factors are. We really don't have a great way to predict this person in this family is going to have these issues, this person's going to have these issues at a different age, or the severity of any of the manifestations. So certainly stress in our experience in clinic makes a big difference to people's quality of life and whether they recover when something happens quickly or whether it takes them a longer time. So, I mean, all these things are connected with sort of general well-being, and that makes a big impact on, you know, healing and functioning and being able to do things you need to do to get back closer to feeling like your baseline. And I know Dr. Shalhub has talked about inflammation and things that trigger inflammation have a big impact. So we think all of those factors matter. We just don't really have a way of measuring those kinds of things for people or predicting what's going to happen.
Thank you. Question for Professor Aziz. Considering vascular EDS issues with colon fragility, Have colonic transplants with healthy tissue ever been considered?
Not really, and it's just because lack of predictability as to whether a perforation will actually occur or not. Many patients never experience any perforations, so one would not consider transplanting anyone just on the basis that they have vascular EDS, and gut transplants are riddled with problems themselves. There are quite a small number of units around the world that are involved in gut transplants, and colonic transplants in particular are very uncommon. Most of the ones that have been done are small bowel transplants in patients with pseudo obstruction. Whether a case can be made in someone with multiple recurrent perforations, that is a possibility, but is again, there are, to my knowledge, no reports of colonic transplants have been performed for patients with recurrent perforation. And recurrent perforations are usually also uncommon in patients, unless there is some instrumentation going on, like colonoscopy and so on, which often is avoided in patients with vascular EDS. There are other ways in which we can look at the colon through CT colography, which is also described as virtual colonoscopy and so on. So I don't think that this is a practical, easy solution to the problem as we know of the current literature around this.
Thank you very much. Question for Dr. Shalhub. Is vitamin C recommended for vascular EDS, or in fact any of the types of EDS?
That's a great question. So the vitamin C connection has to do with an observation that in some patients with vascular EDS, the number of bruises or the extent of bruising improves when they are taking vitamin C. This is anecdotal. It has a hypothetical explanation in terms of presuming that there's increased secretion of the collagen from the cells when somebody is on vitamin C, because it's a cofactor for collagen folding. That said, there are no trials to support that it makes a difference. I think of vitamin C as in the category of low side effects, and if any, it's a cheap medication, it's ubiquitous. I put it in the category of it is not harmful and may be helpful. So I tend to recommend it based on this discussion that I just mentioned.
Thank you. And a question to Dr. Hakim. When should children be evaluated by a geneticist, if ever, for a diagnosis if there is family history of EDS?
Yeah, sure. I mean, I might actually revert to Professor Malfait over this on the grounds that I'm not a paediatrician. So I don't see anybody under the age of 18. But if I might sort of give a general comment, I think if you have a parent, mother or father, who has a known genetic disorder, then essentially from early infancy, the child would be being assessed to determine if there are any particular complications, because some of them do arise very early on. So clubfoot, congenital hip dislocation, for example, a number of features may be very obvious very early, in which case I would think it would be highly appropriate to investigate further with the relevant genetic analysis. When it comes to assessing children for hypermobility and joint instability, and also the capacity of children to follow instruction and for therapists to be able to treat them, my pediatric therapists would tell me that really from about the age of 3 onwards, you can start to consider appropriate assessment of children and other clinical diagnoses, like, for example, the presence of hypermobility spectrum disorder or hypermobile EDS. Although there are challenges through childhood with those 2 particular diagnoses, because things take time to change. And again, I will have addressed this in my talk tomorrow around childhood into adolescence. in those conditions. But I don't know whether, Fransiska, you have any other thoughts about maybe sort of early pediatric assessment?
It depends. For the types where we do have a familial mutation or pathogenic variant, we can do genetic testing in the children, and so if there would be a suspicion that the child has inherited the disorder from one of the parents, then we can do the genetic testing, and it's really a shared decision with the family, with the parents, and or with the child, depending on the age of the child, whether and when we will do the genetic testing. Sometimes, like in classical EDS, the clinical diagnosis can also be really clear, and you actually don't really need the genetic testing to confirm your clinical diagnosis. For hypermobile EDS, in my personal opinion and experience, in very young children under the age of 10, I would say it's sometimes really difficult to say in a hypermobile child whether this is hypermobility that is within the range within the normal range, and that the child will, like, let's say, grow out of it, or whether it will develop towards hypermobile EDS or towards hypermobility spectrum disorder. So we tend to not diagnose small children unless there is something really clear in the clinical presentation, but follow them and see how it evolves into adolescence.
And that's certainly been the guidance from our paediatric working group within the International Consortium. So thank you.
Thank you.
Great, thank you both. And Professor Malfait, whilst we're thinking about childhood and adulthood, people are asking, why do symptoms start in childhood in some people and in adulthood in others?
Well, again, I think, well, not any patient with EDS is the same, nor any family, nor any type of EDS. So for the types where we do find mutations, I think if you really know that there is a problem there, you will see the signs and the symptoms in the children, even though they do not have complaints from it. So in the families where we are really sure that there is a classical EDS or a hypermobile EDS, if you know that it's there, you can see signs and symptoms from very early on. But the real complaints can start later. And I guess for hypermobile EDS, it's the same, but you cannot confirm a diagnosis from very early on. So that's what makes it difficult. But I'll come back probably to the previous questions that was answered by Lauren. Yeah, there are certain things that can trigger the onset of the complaints, and that could be, yeah, stress-related factors or an injury or trauma, or so we don't really know exactly why in one person it can start at an early age, and in another it can take years and years before you can really have complaints. And even within one family, even within, so people with the exact same mutation, we see great variability in onset. So there are still factors that we cannot explain there.
Thank you. And a question to Dr. Burrows. Should staples be avoided for surgical closure?
Yeah, good question. I think the short answer is yes. If there are alternatives, then I would suggest alternatives. I think, I mean, staples tend to be used where there's not a lot of tension on the skin. So it's usually where a surgeon's gone in, wants to go in deeper, do whatever procedure, and then just close the skin. They're not used where the wound is under tension. So we certainly wouldn't want to use them for any traumatic wounds in EDS. But I think it is best to avoid them if we can, because they're quite, what's the word? They're sort of quite traumatic things to put into the skin. The surgeon can't control the tension of them as well. there's sort of more nuance with putting sutures in, and so I would suggest generally that the fragility of the skin, it's best to avoid staples if possible.
Thank you. Question for Lauren. Is there a way to get your family to come forward for testing when they're clearly suffering like you, i.e. blood relative?
Sure. So this is, we see this all the time in many genetic conditions where somebody's been diagnosed, they have a clear pathogenic variant in a gene, and they desperately want all their family members to get tested right away to find out if they have this condition or not. And, you know, people don't always do what you want them to do. One thing that I have offered to family members who are reluctant is, why don't you come in and talk to me, to a genetic counselor, to somebody else on the team. We will not do the test. You come in and have the conversation. We'll talk about the risks and benefits. We'll talk about, you know, what's making you worry about doing this. With absolutely no obligation. I think people sometimes assume that if you go into the clinic that does this thing, you're going to have to get this thing done. And so just, you know, floating that idea of having an initial conversation with zero pressure to actually do the test. Very often people will end up doing the test at the end of that conversation because you've addressed the reason that they didn't want to do it. Beyond that, every family's different, and, you know, if I knew the secret to get your family members to do what you thought they should do, I'd be a very wealthy person.
Thank you. And I think that, Lauren, we're having a bit of trouble hearing everything. I think there's some connection issues. So I think one of my colleagues is going to reach out to you to see if we can fix that. So apologies if anyone had any issues hearing that. Okay, a question for Professor Aziz. What is the recommended management of global dysmotility of the GI tract?
Good question. There are some patients who have a more general dysmotility involving the entire gastrointestinal tract. You can call it global or pan-GI dysmotility. And the general principle there is to try and improve function and improve movement there by using stimulatory medicines, which are called prokinetics. There are some prokinetics which increase the muscle movements of the gut by releasing certain chemicals called neurotransmitters. And one of them that is available throughout most of Europe is called prucalopride or Resolor, and that will have an effect on the entire gut. It's mostly used in the management of constipation, but there are studies that show that it is effective for the stomach and for the esophagus as well. Where there are more regional problems, where the predominant problem is in the esophagus or the stomach, then there are some other medicines that can be used to improve function. For instance, there is a drug medicine called domperidone, which is often used in the management of nausea and vomiting. It also has a stimulatory effect on the upper gut. There are other medicines like metoclopramide and a couple of antibiotics of the same family, erythromycin and azithromycin. They all have effect on improving motility of the esophagus and stomach. They are often used to treat, for instance, gastroparesis and so on. But the only one medicine there in certain parts in Asia, for instance, in Japan, there is another medicine called itopride, which is available, which is very similar to prucalopride in the way it stimulates the gut. So there are some medicines out there which can improve global or motility in the gut.
Thank you very much. I've had one question come in that I'm going to actually answer. Someone said, can we discuss and put together a go bag of hospital and emergency room plans with instructional sheets, etc.? We are really proud of a group we have called the Comorbidity Coalition, and we've been working hard over the past year of putting together toolkits and pathways, and the emergency room is one of those that we've put together for all the different types of EDS, and we're hoping that that's going to be available towards the end of this year, beginning of next. So please keep an eye out for that resource on our website. So that certainly is something that I think will be very, very helpful. Okay, question for Dr. Shalhub. What should we tell friends, work, etc., who might need to act quickly should we present with an issue in vascular EDS?
Having the knowledge of knowing that there's a risk for rupture or dissection, which can present with severe pain. If somebody is having severe pain, the initial response should be, I am having severe pain, this is not normal, and I need to be transferred to the emergency room right away, so please call 911. I've had patients also have information, depending on where they are, sort of part of this literal go bag, if you will, mentioning that they have the diagnosis, they have their bracelet, and they have the information also posted in their house, so that if they are home alone and 911 was to arrive, there's instructions as well. But if you have colleagues, also it doesn't hurt to say at that time that I am having symptoms that are not normal, I'm having a lot of pain, I need to be seen in the emergency room right away.
Thank you. Question for Dr. Hakim. Do EDS symptoms, this in specific is referring to hypermobile EDS, improve, remain stable, or worsen over time, mainly in reference to dislocations?
Yeah, so the answer is all three of the above, because people are different. So let's consider some examples. Somebody may have a series of symptoms that are highly responsive to different treatments, be they medicines, physical, pain management, etc. And therefore, although they may continue to have or will continue to have a vulnerability, their symptoms are under much better control. And so you wouldn't say they didn't have hypermobile EDS, but they may be less symptomatic. Indeed, there are likely to be people in the general population who have asymptomatic hypermobile EDS. They've just got physical signs, but they haven't developed any problems. Then we'll see a group of patients who may, for example, have been deteriorating over the course of time, and what we are able to do with the different treatments that we have available is stop that level of deterioration. In other words, kind of hold them, if you like, in a steady state through the interventions that we have. So their experience of their condition will be that they are stable. Unfortunately, there is, and this is inevitable in all areas of medicine, a group of patients who will not respond well in one way or another to the different treatments that we have, and their experience will be that they continue to deteriorate. It may be that the treatments that we've been able to put in place have slowed down that deterioration, but that's very difficult to predict. So the truth is, we see all those patterns.
Thank you very much. And a question for Professor Malfait. What is the true prevalence of all types of EDS and HSD together? And does that mean that these are not rare diseases?
Well, that's a very difficult question to answer because we actually don't know. The general prevalence of EDS as a whole has been estimated to be 1 in 5,000, which would make it a rare disease. A rare disease, as you have seen probably in the talk, is defined as affecting fewer than 1 in 2,000 people. Well, it is in Europe, or less than 1 in 200,000 people in the USA. 1 in 5,000 would make it a rare disease, but the problem is that we don't have good numbers. There have not been good epidemiological studies for any kinds, for any types of EDS, so we don't know the true prevalence. And also not for hypermobile EDS, especially not since the new criteria were published 3 years ago. So for the other types of EDS where we do find mutations, they will still remain rare diseases. For hypermobile EDS, we would have to have good epidemiological studies to know exactly what the prevalence would be. But I think even there, if we follow the new criteria, it would still fall probably within that range under 1 in 2,000 people. So, but the short answer is we don't know the exact prevalence.
Thank you. A question for Dr. Burrows. How do you see these skin signs in those with darker skin? Are there pictures available of skin signs of those with different ethnicities?
A very relevant question, of course, and it's something actually I've been giving some thought to, not only for EDS, but just generally. And apologies that all the photographs I will have shown, I think, will all have been in white skin, and appreciate that that is an issue and something we're addressing, and maybe something as a society we need to think about as well. In terms of the scarring, well, I think that's not difficult in dark skin. I think where it can be slightly more difficult would be trying to see those veins. So I talked about in vascular EDS where the skin is thin, and because it's thin you can see the venous network there, the blue veins underneath, and that can be a little bit more difficult in dark skin if you're not used to it, but they're there. I mean, it's not that they're not visible. So everything that we do see in white skin is available and can be seen in dark skin. So it's just a matter really of training the eye. It's not that you can't see these things.
Thank you, that's helpful. And absolutely, we are definitely focusing, prioritizing on that. And we agree there needs to be more information out there in that area. A question for Lauren, we're going to see how your Wi-Fi is doing. What type of doctor is recommended to oversee an entire case? I'm at a loss for who should be helping oversee my records and looking at everything as a whole.
Our recommendation for our patients who mostly have vascular EDS, the people that we kind of follow long-term, is to find a good primary care provider who's willing to be a quarterback, somebody who has experience managing a complex condition. And there are lots of complex conditions that are not genetic, lots of other genetic conditions. So it doesn't have to be somebody who knows all about EDS. Really what you want is the skill set of managing a complex patient, keeping in touch with the different specialists that they're seeing, and making sure that all of their information lives in a place that's accessible to their whole team.
Thank you. A much better connection. We heard you great. Thank you. Question for Professor Aziz. We are running out of time, but we'll try and get through a few more. What if any correlation exists between EDS and gastroparesis? What are the tests needed to determine if a patient has gastroparesis? And are there any differences in treatment for those with EDS as opposed to something like diabetes?
Good question. So there is a association. So in our EDS patients, we do see problems with function of the gut rather than structure of the gut. And the most common problem that we see with the function of the gut is that the gut is slow and tends to affect different parts in some patients, and some all of the gut is slow. So we do certainly have patients with EDS who have gastroparesis. More commonly, gastroparesis is I always consider it to be a rather extreme term, which means paralysis of the stomach. Mostly this is mild to moderate delayed stomach emptying, and it produces symptoms. Now, this is an association. It occurs in many other conditions, but in some of our patients, we cannot identify any other condition apart from EDS. There is no data on exactly how common this is, but we have data about how common a condition called functional dyspepsia is in EDS patients. And in functional dyspepsia, which basically means you have indigestion type of symptoms without there being any ulcers in the stomach. And the prevalence of this condition is roughly about 50% of all patients who present with indigestion type of symptoms without ulcers. So it's a very high prevalence of EDS, hypermobile EDS and HST in that population. And a subgroup of them have got delayed gastric emptying as well. So I think the overlap with functional dyspepsia is really the most important thing. And yes, there are treatments are the same as those of diabetic gastroparesis. You stimulate, try and actually use dietary measures of small frequent meals, reduce the fat content of the meal because fat slows the stomach down. And then if these measures don't work, then you try treatments like metoclopramide is, I think, first line in the US. In the UK, it's domperidone. And then going on to erythromycin or azithromycin, and finally tupocalpride. So those are the sort of treatment ranges that we use.
Thank you so much. Okay. Question for Sherene. Are vascular EDS and intracranial hypertension associated?
So for the other people who are listening, the other term for this, the other terminology for this is pseudotumor cerebri. No, I've not heard of any or seen any. Pseudotumor cerebri can also present with headaches. Headaches I've seen more commonly in the population with vascular EDS, but I don't think it's related to this particular condition. So it's probably true unrelated.
Thank you very much. Okay, we're going to have this final question, and I don't think there's anyone better to answer this other than Dr. Hakim, who runs our EDS Echo, and the whole concept and belief behind this is to try and teach as many people about how to treat people with EDS and HSD around the world. And so the closing question, Dr. Hakim, is what is the one thing that you think every doctor needs to know about EDS?
Okay, they need to know whether they can listen well or not. And if they can't listen well and they don't have compassion, they shouldn't be seeing our patients.
Perfect answer. Thank you. And I think that sums up everything and the amazing speakers we've had today. So that's the last question. Thank you all. We're going to now move into our final videos of the day. Thank you, everyone.